Session. Today we're going to talk about management of suspected and confirmed COVID-19 infected dead bodies. And our speaker today is Dr. Walong from University of Nairobi. He's a pathologist at the Department of Human Pathology. And also we have Dr. Johnson Odwor online, available to answer any questions that you might have. Dr. Johnson Odwor is the Chief Government Pathologist. And I can also see a few pathologists also online. So welcome to today's session, Dr. Walong.
Right, thank you very much for inviting me to this session. I hope you can hear me with my mask on. I'm only used to dressing up like this at the autopsy room, but the current recommendations is that we must be in masks always. I didn't see anything about goggles, but pathologists must be extra vigilant about these things. Anyway, so today I'll discuss about the dead body management of the COVID-infected body, and I'm happy to be doing this presentation with my colleague, Dr. Johnson Odwor, who has been working very hard on developing procedures for this situation. I have a few conflicts of interests, potential conflicts of interests. They're not really conflicts as it were. I have received research funding from the Minimally Invasive Tissue Sampling Alliance, an offshoot of the Gates Foundation, to set up a training hub and implement the use of a minimally invasive tissue approach for disease surveillance in East Africa. I'm not receiving any funding to support this presentation. So the facts the current facts concerning this disease, we know it's severe, mainly affecting the respiratory tract. We know it's infectious, and we know that the cause is a novel coronavirus known as SARS-CoV-2. And globally, as of today, there are 1.3 million infections in 200 countries. And clinical outcomes, 270,000 recoveries, 70,000 deaths, with a case fatality rate that varies from 3 to 8%. And in Kenya, we are looking at 142 cases, 4 recoveries, 4 deaths. And in terms of mortality, so currently there is no evidence of transmission due to contact with a deceased person. However, for purposes of biosafety, the SARS-CoV-2 is designated as a hazard group 3 infection, and I'll basically describe what that means. And because of this, we need to optimize management to minimize potential risk of infection. And this group summarizes what a hazard group 3 means. And specifically in this, we know that it's a group 3 because it can cause severe human disease. The hazards to workers are likely and possibly serious. The spread to community is also likely. And we know that there is effective prophylaxis. Okay, there is no, prophylaxis is not effective, but there are preventive mechanisms that are currently in use. So SARS-CoV-3 joins Bacillus anthracis, hepatitis B virus, hepatitis C virus, HIV, Mycobacterium TB, and Salmonella within that hazard group 3. And we know that in a group 3 hazard, we have to use primary containment and prevention, consisting mainly of gloves, lab coats, eye protection, and these have to be worn as per the hazard use. And of course, protection has to be biosafety level 1, plus physical containment for splashes, aerosolization, centrifuge blenders, and biosafety cabinets. So how does that translate to the dead body management? And that's what I'll be describing today. I will describe what we think is ideal body management for hospital and community deaths, ideal transportation, disposal, appropriate death notification. When we feel those cause of death statements, how should we do it? I'll touch a bit on medicolegal and autopsy in COVID, and of course, mass deaths. So we go in and look at the ideal body management for hospital and community deaths at the site of death. So we expect that most of these deaths will occur during care. And we know that hospitals are controlled environments, And key personnel who are present in most hospitals include physicians, nurses, and of course, mortuary technologists. And as I've mentioned earlier, our requirements have to be consistent with the risk, the category 3 risk of this infection. And therefore, we must have splash protection as part of PPE. And of course, this is an aerosolized and droplet transmitted infection. So appropriate personal protective equipment must be used. And when death is declared, the body is tagged and immediately placed into body bags, which need to be tamper-proof, leak-proof, and preferably we are thinking of double bagging so that we minimize contact as much as possible. And the outer surface of the body bags used need to be cleaned with 0.5% hypochlorite solutions, and we'll discuss that later. About the so-called last offices and removal of indwelling medical paraphernalia, we prefer that these ones should be left in place because we think that there will be additional risk to healthcare staff during removal of this, and plugging of orifices with various material to prevent leakage should be avoided. Right, so this, of course, this is not the plan of a KNH IDU, but we think that most individuals will be in an isolation mode, and if ever there's mortality, these bodies will be transferred to the temporary mortuary, as it were. And we think that the body bag may be placed within the temporary mortuary or on the bedside. But the procedures for that should be agreed on and implemented in that situation. When developing your procedures, please have a chart of, you need to draw a plan of your facility so that you know which direction the bodies will be moving through and which direction personnel will be moving through. So map out flow of these bodies. If there's a temporary morgue, state it. And of course, the contamination of bed surfaces as per the protocol that has been presented. Now, community deaths, these ones are a lot more complicated because this will occur in uncontrolled environments such as the homes and streets, and medico-legal considerations are essential in these cases. And the scene is of interest, and access to this has to be granted by relevant homicide investigating teams. And this site has to be considered infectious and may be particularly difficult to decontaminate, especially prior to the response. So imagine a scene like this. I have to apologize, I have to use real life pictures to contextualize what you will see in our local situation. So this is a middle-aged lady who was found dead in her house, and you have a scene that is definitely cluttered with household material in this manner, and you can see that there are various fluids that are contaminating the bed sheets, the carpets, and so on. And you can see how complex such a scene is. And therefore, approaching this scene, you have to be totally prepared to deal with it. So what is the ideal approach to this? Of course, we know that in such a scene, the medico-legal investigation is a priority. And we have to consider 3 broad processes when we are approaching this scene. So there is a need for antemortem information concerning the specific death and processing of the death scene, including the body retrieval, transportation to the designated mortuary, the autopsy, and then the reconciliation of the autopsy information and the antemortem information to properly identify the deceased person. So what are the practical aspects? We hope that members of the public will keep off the scene and security arrangements have to be in place. The key persons who must be notified include the police, the public health team responsible for the region, mortuary personnel, and of course, oversight from a regional pathologist who may or may not be present at the scene. And if you look at the scene I've shown, you can see that there are various risks. There are biological hazards, there are physical hazards, and we have to minimize whatever harm that can occur to the response team and we definitely need personal protective equipment suitable for the hazard group 3 organism that we are dealing with. So for this scene, there has to be a checklist. There has to be a standard procedure. There has to be, the responding group have to map out the building and the room, and of course designate sites for PPE donning and doffing. And this is a rough sketch map of one of those scenes, definitely not the scene I've shown. I've made it blurred so that you cannot read what has been jotted on those notes. So in this scene, for example, before you approach, suppose the body is in this room over here, you can see that there's a sketch map and we can see how the layout of the house. You have to have an idea of how you will enter and exit. And of course, you have to have an idea of where the PPE will be donned and will be doffed and how you'll manage your wastes that you generate over there. So, processing of the death scene. You look, but you don't touch. So you have to come in and do an initial appraisal of the scene. You definitely need good cameras and the like. The response team, I'm assuming that most of our audience here are medical personnel. So your job will be to mainly recover the body or body parts. And the more complex the scene, the greater the number of medical personnel you require in that scenario. And these people should have the relevant experience for that. So once the scene has been appropriately processed, then the bodies need to be placed into the body bags. And the body bags, just as I mentioned previously, should be tamper-proof and leak-proof. Double bagging is preferred, and you may need to append labels before you can transfer the body to the morgue using dedicated transport vehicles. Of course, a lot of this information, our context will be different because we may be operating in situations such as this. Our houses are more dense, in urban areas are densely constructed without adherence to various building codes, and therefore access will be difficult. And of course, you may need to, as you can see in this picture, there's a volunteer who may be a member of the public and has some idea, some PPE, but not at the level 3 group. So of course, in your context, you need to see how you're going to properly utilize the personnel you have. And if you have volunteers, how you're going to use them. And you can see the transport vehicle that you're using here is a repurposed pickup. In our context, we'll mainly be using police vehicles. However, the teams that are at various counties or regions need to start thinking about this and see which vehicles will be designated for this task, which staff will be going for these specific recoveries, and how you will interact with the members of the public. And of course, again, another picture borrowed from the Ebola scenario, which is a hazard group 4. You can see there's good containment of the body in the body bag, and there's ergonomic use of the carriers. Here, I think they're using a spinal board or something that they have repurposed for that. There's a presence of security. You definitely need security personnel involved in all of this. And well, we all know the peculiarities about the members of the public that we'll be dealing with. So definitely, if most of these cases may not have a proper diagnosis of COVID-19, or we definitely do not know what the diagnosis is, therefore they have to be handled with utmost care. And an autopsy will definitely be indicated for this. The approach to the autopsy I'll discuss a bit later. However, minimum requirements will be that at least a good external examination should be performed. And if there's need for sampling of tissues for confirmation of disease, then minimally invasive techniques are preferable. The presence of COVID-19 does not mean that the medico-legal investigation should not be comprehensively done. And that is why the regional pathologists need to be involved in this response. And the complete diagnostic autopsy, where indicated, has to be performed in a suitable autopsy suit by appropriately trained personnel. And I will not definitely go into the detail of this. Right. So ideal transportation and storage. So the body bags are preferably decontaminated prior to transport, especially external aspects. This is easier said than done. Suitable vehicles and means that are dedicated to transport the body should be deployed. In hospitals, such as KNH where I work, we have dedicated trolleys. And in community deaths, we think there should be dedicated vehicles. And these vehicles should not be utilized for other purposes, for example, ambulances or police vehicles for transport of suspects. If it's a body transport vehicle, then as much as possible, it should be utilized for that role. And the contamination of vehicles using standard procedures is essential, and minimal contact by members of the public. How about refrigerated body boxes? Maybe. So this is a picture, of course, I got off the internet, showing a van that can be ideally suited for this purpose. And that, I know in our country, we do not have a shortage of this kind of vehicle. Freezer boxes, we may not have sufficient supply of this, but if possible, this should be procured for this role. Some situations may require that the bodies are transported over maybe a distance or may need repatriation. Therefore, these boxes may be considered. Dr. Dori will probably mention about repatriation later. Right, our local situation. What do you think is wrong with this picture? Please type it in the chat box. What you think our situation currently is and what you suppose should be the remedial steps taken by the authorities to prepare for containment of such deaths. Right, so next I'll look at storage, and we definitely suggest that there should be dedicated mortuary spaces where there's no commingling with other bodies. In the absence of this kind of these mortuaries, there may be need for refrigerated trucks or other approaches to body management and storage. And let Dr. Dwar discuss more about what to do, especially when you cannot access such facilities. Right, so within the mortuary, we expect that the bodies should not be removed from the body bags. They should be left intact. Additional procedures such as embalming, washing, touching of the bodies are discouraged. And of course, with the fact that these body bags should be closed, there could be curiosity to examine what's inside, and therefore tamper-proof seals are required on each body bag as much as possible. Now let's look at disposal. So last week we saw the publication of the Public Health Act regulations by the minister, and it describes that the disposal has to be supervised by a public health officer or medical officer of health. No gatherings allowed with a maximum of 15 persons, and various other rules, for example, barring children under the age of 12. And that transportation modes need to be decontaminated immediately. And of course, the times for burial should be stated as such, or cremation. And I won't go further into the detail of that. Now, the fourth area I'm going to discuss is appropriate death notification for COVID-19 deaths. And when a death occurs, we are expected to properly fill this form. We know from the work we've done on mortality that we have challenges in proper documentation of the D1 form, especially part 12 that describes the cause of death. Okay, and the cause of death is classified here as the immediate causes that are linked to the term due to because they imply the causal pathway, and other underlying disease conditions. As you've seen that in COVID-19, we see that there are lots of underlying diseases that have to be identified, and this should be described here. Okay, so this is an example of a simple, for example, an individual who does not have comorbidities. So the immediate cause of death in most COVID cases will be acute respiratory distress syndrome, and it should be described as such. And the underlying, and this is definitely due, it's not as the morbid condition that is causally linked to this is the infection COVID-19 or the COVID-19 disease. And this will be the ideal approach to this. We hope we will not see cardiorespiratory arrest described here or other diagnoses that are described as junk diagnoses. And if there's any other condition in the causal pathway, it will be appropriately described. And if there's a contributing condition such as diabetes mellitus, then we expect it described in this area. We expect that this, if filled in the ward, you will probably select the part A, stating that you attended to the deceased before death. Okay. This information can also be documented by a pathologist, and if a pathologist has performed an examination of the body, a post-mortem, then part C should be properly documented as such. Now, there is this part B, and Dr. Dur maybe will mention it later, where a body is examined after death. The challenges we have with part B is that the approach, or the standardized approach to this examination is unclear. Are we talking about a verbal autopsy or a different an appraisal of the clinical records? So part B needs to be further clarified, but part A and part C are definitely very clear and important to indicate. So I'm showing D1 that of a recent COVID death, and we see that in this one, the immediate cause of death is described as cardiac failure. And as we mentioned, these diagnostic terms that are imprecise and cannot be properly coded by ICD-10 should be avoided as much as possible. And if aplastic anemia is the underlying condition, then we expect it to be documented here. But maybe at a different date, we can describe appropriate documentation of cause of death. So the considerations are that the physician with the highest competence should fill the D1 form, or should properly supervise the filling of this D1 form. We know that proper death notification is important for surveillance. The teams in public health will definitely describe that the challenges they have with inappropriately filled death notification forms. The usefulness for medical-legal triage, part of my work is to sit at the mortuary and look at the D1 forms and identify which ones maybe are inappropriately filled for the specific conditions, so that cases for medico-legal autopsies that require medico-legal autopsies are not inappropriately discharged without a medico-legal autopsy. So a properly filled D1 form becomes a very important tool for medico-legal triage and identifying these cases. If the cause of death is unclear, then this form should not be filled. Instead, the regional or hospital pathologists should be consulted, and I'll show you customized hospital documentation that may be consulted, that may be filled instead of the D1 form, so that the consultative process can begin and a proper death notification form developed. We must avoid junk diagnoses such as cardiorespiratory arrest, and hospital documentation, as I mentioned, may be considered in these situations. In Kenyatta National Hospital, we already have forms for request of the clinical postmortem, and this is a simple informed consent form. And here's a more elaborate form that describes the cases that should be filled instead of a death notification form, where in the judgment of the referring physician, a postmortem should be performed. And you identify that most of the causes described here are those that are described in the National Coroner Service Act number 18 of 2017 that itemize and state exactly which cases require autopsies of forensic autopsy. And if a clinical autopsy is indicated, then the clinician or the physician will describe exactly why they would like this autopsy done and perhaps attach a clinical summary for its use. Of course, we are not currently applying the National Coroner Service Act because of certain legal issues related to its implementation, but the deaths that should be investigated are properly itemized. And even if they are COVID-19 related deaths, may be exposed or confirmed, then these considerations need to be properly fulfilled. Right, now look at the medical legal system and the autopsy. So a COVID-19 diagnosis or suspicion should not limit the medical legal investigation, and that's for obvious reasons, and I won't expound further. If any autopsies are required, they must be performed by appropriately trained teams of pathologists and their assistants. The minimally invasive tissue sampling technique or limited autopsy approaches may be considered by the pathology team, and a complete autopsy may be performed only when absolutely indicated in the relevant environmental setting with appropriate techniques, which I will not go further to describe. And the pathologist here, being the senior most and the professional in charge of this process, must ensure best standards in biosafety relating to the appropriate hazard group of the organism that is being, of COVID-19, as it were. Right, so there are many reasons why an autopsy will be performed, and I won't itemize them. And this picture is one that was published in South Africa, and here they're using a level 4 biosafety facility with, you can see there is hooded oxygen presentation, and the body is wrapped in a sheet, and they're performing minimally invasive autopsy procedures using core needle biopsies to sample various tissues. We definitely will not need this level of protection, but the pathologist has to ensure everybody in the entire chain is safe. Right, mass deaths. Situations may occur where you have maybe 5 or more occurring at close proximity, and there may be disaster situations due to maybe fire or structural collapse of a building. And sometimes there may also be surges of COVID-19 deaths in the community or in hospital situations, and this may be treated as mass deaths. So identification of deceased persons is essential in this. Determination of their cause of death is also of essence, and of course, these bodies have to be managed professionally. Sometimes mass graves may be used, and this may be considered as temporary or permanent solutions. So this flowchart describes pretty much how a mass death should be handled. There should be a search and recovery team, and the search and recovery team should recover the bodies using the best standards and take them to a temporary morgue station. And while the bereaved family team should also be contacted for antemortem information or antemortem data concerning that case. An identification center such as the National Center for Registration of Persons need to be involved, because we may need to identify who is here using various techniques. And then of course, inspection and classification of the individuals using personal belongings, fingerprints, and victim identification using forensic autopsy, DNA sampling are essential in this process. So this definitely requires a very dedicated team of specialists, and it needs various resources. And the standard procedure for this approach definitely will be published by the Ministry of Health in due time. Once all these are done, then there has to be reconciliation of the body with the identity, because by this time the body is usually not identified, and then the body can be released for interment, or if unavailable, appropriate interment can be used. Temporary morgue stations may consist of refrigerated trucks, or various other deployable mortuaries. And in these mass deaths, of course, at this point, we may not have an identity, so we're using a place of recovery, a person team, and of course the number, and the various characteristics based on the chain of custody is essential. So chain of custody has to be maintained as well as possible. Right, so this is my final slide. And what is notable is that what we've discussed is that there has to be a dead body policy in each institution. And of course, we expect that the dead body policy, management policy should not just be for COVID-19, but for other deaths as well, because each death is potentially infectious. And if it's a COVID-19 death, then of course the rules should be in concordance to what the Ministry of Health has released or will release. Of course, in certain situations, facilities may be unavailable, so you may need to use innovative solutions, focusing on safety and prudent resource utilization, appropriate documentation of cause of death, and of course, the regional pathologists must be notified, and they have their role in this, the disaster teams, physicians, nurses, mortuary attendants, and each team should develop appropriate standard procedures for dead body management. For those who are in the rural areas where it's customary for burial to occur immediately after death, or where cultures are involved, then of course, involvement of those different groups are essential when describing the response to the dead body management. Good, so I've got many people to acknowledge in this presentation: the University of Nairobi, Kenyatta National Hospital, and of course the Kenya Association of Clinical Pathologists and the Ministry of Health. And I hand over back to the chair of this session, and thank you very much.
Excellent. Thank you so much for that presentation, Dr. Walong. It was clear and very brief and simple to understand. We thank you so much for that. Dr. Johnson Odor is online, but before I get Dr. Johnson Odor to share more with us or to add onto what you've said, I'd like to ask a question. You've mentioned the Public Health Act that was published on 3rd of April this year, the Kenya Gazette Supplement number 39. It's on Public Health Prevention, Control and Suppression of COVID-19 Rules 2020. Now in there, there's a part where it says the Cabinet Secretary may designate an area as a burial site for persons whose death result from COVID-19. So my question is there an area which has been designated in either Nairobi or any part of Kenya? And my other question is, if a family requests for a post-mortem, now that in the Act it's not explicit that you can't have a post-mortem done. So if a family requests for post-mortem, knowing that a patient died from COVID-19, are we doing them? And also, I'm also interested to know, are the bodies still shedding? Are they still infectious now that we're putting them in a double bag because of the body fluids? Are we worried that the body might still be shedding and thus be a risk? So that's why we are requesting people to bury within 24 hours. Or what is the rationale behind the 24-hour that the Cabinet Secretary, the Chief Administrative Secretary of Health told us about on Friday? So Dr. Odor, let me unmute you so that we can hear you. Oh, you're already unmuted. Yes, Dr.
Hello, how are you?
Hello.
Yeah, thank you very much for the invitation to this sensitization exercise.
Yes.
We know that we are battling a disease which not so much is known about. Mm-hmm. And with a disease which not so much, but not everyone know about, and not so much is known about, we need to be having a lot of caution when we do everything. Yeah. You've talked about, okay, Dr. Walong, thank you also for the presentation. We did a guideline with Dr. Walong together with a group of pathologists. And I think everything that he said is what is the guideline, and I don't need to repeat much. The only thing I like to say is we need to be very, very cautious when we handle these bodies. Why? Because first of all, we don't know, this is a new disease. We don't know much about it. And there's a question that you asked as to why we are burying the bodies within 24 hours and why we double bag it. Yeah. And whether the virus is still be shedded. Yeah. Okay, the first thing I'll answer it this way. First of all, we want to avoid anything that will cause, aerosols, anything that will cause splashes and all that. And because we still don't know how long this disease will remain in the body, the virus, what we want is to ensure that the body is not manipulated. We avoid manipulation as much as possible. Secondly, from what we've seen in other parts of the world, we are right to, to make a projection on how many people die. Right now, not so many people have died around, but we don't know what will happen tomorrow or next week or the other week. So we need to be prepared. We are thinking of a scenario whereby, say, for example, you've seen in Italy, you've seen in Spain, like 800 people are dying in a day, or 600. So we should be prepared. Okay, that's why we decided now that the body should be buried within 24 hours, so that now we decongest our mortuaries. Yes. I think that's how I wanted to answer the question. You've talked about postmortems. Hello, can you hear me? Hello?
Yes, we can hear you. Hello, we can hear you, Dr. Odor.
Yes, we've talked about postmortems, and Dr. Walong has elaborated very well that autopsy should be done in a very appropriate setup, as the reasons are the same. Postmortem involve a lot of aerosol which come into the air. We know how our mortuary infrastructure is. We don't want to leave the mortuary and leave the mortuary with as a focus of infection. That's why we avoid postmortem as much as possible. However, if it's done in a very appropriate setting, we'll be okay with it.
Yes.
Yes.
All right. Is there anything else you'd like before we go to the question and answer session, Dr. to add?
Probably I'll wait for the question and answer because everything Dr. Walong has elaborated very well.
All right. So there's a question from Abtom Hagos, and it's more of a comment. He's saying to protect the community in such situations is to select from the community social workers and brief them who will facilitate the transportation at home level. I don't know if those logistics are in place in case we do have deaths that are occurring in the home state. From the Public Health Act that was published the other day, we can see that it says very specifically that if you're owner of a premise, if you're residing in a premise, if you live within a premise where you suspect somebody has died of COVID-19, you're supposed to inform the medical officer, the nearest facility, or the public health officer. But now it is asking a question that are we able to get the community social workers to facilitate transportation from the home level to the funeral home or to the burial sites?
I think when you're dealing with a pandemic of this magnitude, we need to stick to the Public Health Act. And the Public Health Act is very, very clear about the notification of deaths and the notification of the public health officer or a medical officer. And I think when this community social worker work with these people, they'll be able to work together and they help. We are in the process of capacity building, helping, first of all, in the course of the week, we are going to capacity build the morticians on how to deal with the bodies. We want also to capacity build the policemen, because I've seen the policemen are usually very, very worried and they're scared of this because we know why. We are also capacity building the other doctors, and I think we'll go up to social workers also to be able to tell them what to do, because some of these instructions are not very, very difficult. They only need to know what to do. Yes.
Okay. So Dr. Long, this is for you from Dr. Diana Kemunto. She's saying there's a lot of buzz online about death from COVID and death from COVID-19 and death with COVID-19. From a pathologist's point of view, is there a criteria you use to determine that a patient died from and not with COVID-19 in particularly in context of comorbidities?
Well, that's an amazing question, Dr. Dan, and I hope you're one of our, you should join pathology if you're not a pathologist, or you should somehow consider joining or participating more in the cause of death, what we call the decode panels. And the decode simply means deciding the cause of death, because there are various rules in ICD-10 that describe how we should assign cause of death. And the main thing, and I can see the gist of your question, is identifying whether COVID-19 is truly in the causal pathway of that death, or it's a contributor, not necessarily in the causal pathway, but it's there, but someone dies actually of something else. And that one, I must say, it's a question that we may need to deal with at a different forum, where we have to strongly apply the cause of death criteria. The other things, well, COVID-19, of course, is a new disease. It's an emerging infection, and the pathology of COVID-19 is yet to be conclusively described. And of course, there's need for research in areas, clinical-based descriptive research that identifies the actual pathology of COVID-19. But before we do that, then we cannot properly separate COVID-19 as a contributing diagnosis or as a disease that's present within the causal pathway. So from a practical suggestion at the moment, we should consider all positive COVID-19 diagnoses as part of the causal pathway. And we should say that the patient has died from COVID-19, especially in the right clinical context. Of course, there'll be exceptions to this rule. Maybe someone has a new diagnosis of COVID-19 and has jumped off a building, right? But still, even then, we'll have to look at the neuropathology of COVID-19 and see how it's contributing to that. So yours is a very loaded question that definitely we have to think about deeply and assess as we learn more about this new disease.
And I think to echo what Dr. Olang has said, that's a question which has been asked in so many forums. I remember someone asked about the number of deaths in, say, Italy. And the question is, these people, have they died of, all of them died of COVID-19 or with COVID-19? This is a new disease, and as we learn about it, we'll be able to assign criteria, yes.
Good, thank you for that. There's a question from Edwin Wanjiku. He's saying, thank you, Dr. Olong. Do we have an already set up emergency mortuary? Maybe both of you can, one of you can give us the answer to this. Do you have an already set up emergency mortuary?
Currently, we don't have an emergency mortuary, but what actually we are doing in the document that we are making, we intend to identify mortuaries which we think are safer. Yeah. And one of the mortuaries which we think we're going to identify is Kenyatta National Hospital Mortuary. We have, that's in Nairobi. We have Mbagathi, we have Mama Lucy, and I think Kenyatta University, the new referral hospital, which I think they could be able to handle such cases. And as time goes by, we're going to also identify regional mortuaries, which we think will be able to handle such cases.
Okay, thank you for that. Dr. Long, this is for you from Francis. Francis is saying, thanks for the presentation. I have not seen where application of occupational safety and health standards in the whole issue of body preparation, especially the hierarchy of control. And there's also another from Kibet Kibor Keitani is saying, do we have enough body bags in the country? In case of shortage or lack, what next?
Right, I like those questions. Very nice leadership type questions. And unfortunately, I'm unable to answer both of them. And even as we develop our protocols, we have to discuss with the relevant OSHA designated experts within our hospitals to guide us. And for us, that is still work in progress. About the body bags in the country, let me let Dr. Dor handle that, because I know that there have been a lot of efforts in obtaining the relevant supplies. And since Dr. Dor is also studying law, he can tell us more about the Occupational Health and Safety Act in relation to the current.
I think to answer the part on the body bags, the ministry is in the process of procuring body bags, and I'm sure we've done a projection of what we expect to be the number of deaths, and as we say that each body has to be double body bags, so we're in the process of procuring the body bags, which will be available within this week. As per the occupational health hazard, standards, of course, the law is very, very clear about occupational health standards, and the Act says that the responsibility usually lie on the owner of the building, the management of the institution, and the workers also. So each and every person has a responsibility within the standards, yes.
Okay. Thank you. Now, we've been still talking about the number of deaths. We've seen a lot of modeling being done. There's one that was going around on social media over the weekend, and the person was predicting that we'll have 1.2 million deaths. The modeling that the Acting Director General, Dr. Patrick Amoth, mentioned the other day is that we'll have 10,000 cases at the end of by the end of the month, April. Approximately 10,000 cases. He didn't mention the approximated number of deaths. Are you able to give us a figure on what to expect and how grim the picture might look in the near future?
That will be a very, very difficult question because it's something which is ongoing. In fact, by Saturday we are meeting,
Yes.
and the meeting we are actually in a COVID task force, which we are meeting and making projections. Okay. But there are figures which are varying. Which, if I tell you now, what figure it is, I'll be making a misstatement. But it's a varying figure. So we just need to be prepared based on what you're seeing. Yes.
Okay. Okay. Thank you. But we really pray so hard we don't get to the Italy and Europe situation.
Yeah, that's why we are making all these interventions. Yes.
Yes. All right. So Mario, yours is a comment. Thank you very much. Capacity building is very key for all healthcare workers, doctors, clinical officers, nurses, and other healthcare workers, especially on how to handle the dead at this point. Thank you. So thank you for that presentation. For the people with CPD who are requesting for CPD points, I'll answer you at the end. Now for Kamodo Watenga is saying that now that every death is a corona suspected case until proven otherwise, and the increasing numbers of COVID cases, should postmortem from other causes of death be done, especially in facilities with inadequate resources and PPEs? Dr. Along, should we continue doing our postmortems or?
Well, a postmortem is sort of, we look at it the same way, look at other medical processes. And if we don't do them, we will definitely have a big problem. And because of that, we need to still offering the service to the public especially for the non-COVID cases, we still need to offer the service. But now what Dr. Kamodo Watenga is saying is that it's likely that some of the cases there will probably be COVID exposed or COVID positive. And what I would recommend is that the pathology teams handling these cases should have a heightened risk preparedness, proper use of PPE, and ensure that the resources for those are adequate. In the absence of those preparations, then it will be prudent to, think outside, provide the leadership required, and see how to bridge that gap. Because if we say that you're not performing postmortems right now, good thing is that the public is staying home. Okay, not all are staying home, but there will be other issues that may arise, and we still need to continue offering the service as medical workers. But Dr. Edward might chip in as well on this.
I think what you need to do right now is we should not stop doing autopsies because the legal system is ongoing. What I'll advise is we have utmost precaution. We take a standard precaution, make sure we adhere to PPE standards all through, make sure that our mortuaries are clean, and ensure that if you are told to do autopsy in an environment which is not conducive, don't do it. Things that will generate aerosol, ensure that you don't partake to it, especially, that when you open the head in autopsy, we use oscillators. And these oscillators, as we know, they generate a lot of aerosol. So discourage the use of these oscillators. And I think, just be careful. Splashing of fluids and all that, just be careful when doing autopsies.
Yes. All right, thank you for that. There's a question from Meru Level 5, and I'd like to combine it with also Dr. Abdallah's question. So Meru Level 5 Hospital, they're asking that since the Public Health Act has no section on COVID-19 on dead bodies, how are we going to store or keep the bodies in our public mortuaries? Then Dr. Abdallah Salim is asking, what are the recommended best practices on how to handle Muslim dead bodies from COVID-19? Because ordinarily Muslim dead bodies have to be done final washing and ablution, plus the body is to be buried in white shroud only. Still in the same in the same breath, Meru level 5 is back again asking, when you receive a COVID-19 body in the mortuary, is it supposed to be washed or disinfected surroundings only before burying? How deep will the grave to dispose the infected body be?
I don't know. That question is meant for me or Dr. Along? Or any of us? Hello? Hello?
Yes.
Can I answer the question?
Yes, you can.
The doctor from Meru Hospital has asked about the storage of COVID bodies.
Yes.
What I'll say is we develop guidelines. You know, usually what happens, guidelines are also part of the law when you develop guidelines for the ministry. So the guidelines say is very clear, and is what Dr. Along has presented today about storage. You need a designated area to store all the bodies which are thought to be of COVID. The bodies have to be double bagged. No viewing of the body, no opening of the body bag, disinfection of the outer body bag. And the day that the body is being buried, just put in a coffin, seal, and the body is taken to the burial. As per the burial has to be supervised by a public health officer, the standard burial procedures, nothing much. The number of people in the burial has already been talked about in the presentation. When you're making the guidelines, we actually had the input from the Muslims, and they gave us their input about all that. And remember, we are trying to avoid as much as possible manipulation of the body, because remember, this body is still harboring infectious virus. So the guideline is very, very clear about the handling of Muslim bodies. Yes.
Okay. Thank you for that feedback. From Melissa Wanda, she's asking, thank you, Dr. Along and Dr. Ador. Are we prepared to recruit more staff, especially for postmortem, especially in resource-constrained facilities? And she's also asking if the guidance for handling of bodies has been disseminated to all the counties.
Right, so Melissa, that's a good question, and it's definitely work in progress. And we think that we had a clarion call to all pathologists and members of the Kenya Association of Clinical Pathology to avail their expertise in the regions they're serving, at least to offer guidance, and if a postmortem is required, provide an appropriate environment professionally where it can be performed. And you asked about PPEs. Of course, there's a lot of focus on that, and resources. I think Dr. Dor has mentioned that there are lots of initiatives within the Ministry of Health and other bodies in charge of healthcare working towards availing appropriate PPEs. Dr. Dor definitely can add more on that.
Okay. This issue of more staff, of resource constraint. You know, many of our mortuaries are constrained when it comes to resources. Today, in the morning, I had a meeting with a colleague of mine, and we explore this. And I think I'm going to put it to the ministry that some of these mortuaries require more than 1 or 2 persons in order to be prepared for this. And as per dissemination of the guidelines, I've already forwarded it to the General Health. I'm going to follow up, see whether it can ensure that it go to every part of the country. Yes.
Okay, thank you. From Dr. Nandasaba and Dr. Kinuthia, Rosalind Kinuthia. So Dr. Nandasaba is asking, when it comes to interment of bodies, are families allowed to transport bodies to their rural homes, or should they be interred within the county of death from a public health point of view? And Dr. Kinuthia is also asking, how do you manage cultural issues around internment, such as viewing, dressing the body, handling of the coffin?
Oh, let me let Dr. Dor handle that.
As for interment, remember the rules say very well that the body has to be interred within 24 hours of burial. Yes. And we've given this window because the government is tending to facilitate this transport of the body to the rural areas, so that now the relative don't have a cost implication. You know, some people come from very far-fled areas, and they might need time to to look for money and all that. This usually take time. So the government is willing to help transport the body to the place of burial. So that's why we're talking about 24 hours. Cultural issues, this is a pandemic, so we have to suspend all the cultural issues for now until the pandemic is over. Yes.
All right. Okay, thank you for that. From Ruth Mulu. Ruth is saying, thank you. In case our health system is overwhelmed and the mortuaries are inadequate, like we've seen in countries like Ecuador, are relatives allowed to keep the body and bury within 24 hours?
Oh, that's a nice question. The challenge with a system like that is that we don't want a system that is prone to abuse from a medical legal perspective. And we also want to count these deaths properly. So we think that we should have a mortuary interface in all deaths. And we think each region should have a facility able to at least confirm or handle these cases appropriately. But definitely, from a policy perspective, Dr. Dwar may describe more. And of course, it's also a question that I know in Kenya we may need to describe, because I know in certain, like in a project I was in Western Kenya, where there's a natural death, as it were, I noticed that the chiefs used to sign a certain death notification form and authorize the interment of that body. So again, so those ones, I think from a policy perspective, Dr. Dwar is going to describe further.
I think the only thing I'll say about this is that, it's very difficult for you just to bury a body from the site to the grave without, documentation, notification, all that. So we might still need to have, the body accounted for before burial. That's why mortuary might still be important, yes. Yeah.
Good, thank you for that. We have a question from Abdul Aziz Abeid. And he's asking which COVID patients who die in isolation should have a postmortem now that we have reports of sudden death. Still in the same breath, Kennedy Masika is a wonderful presentation, though joined a bit late. Should a pathologist then put full PPE when doing an autopsy in regards to SARS-CoV-2? So are we doing any postmortem for any of the patients who die in isolation?
So at the moment we haven't been doing, but we, as the experts are developing certain rules, because we will definitely have situations where, and we know from our autopsy practice within the hospital, we will have situations where these autopsies will be indicated even if the death occurs within the isolation setting. We also have, we may also have certain protocols. We do not know, maybe we will start performing clinical trials. And as part of the clinical trial protocols, we may also need autopsies to be part of it. But those ones definitely are currently evolving. At the moment, the rules are not yet already there, so we shall continue discussing that. Concerning PPE, of course, it has to be as comprehensive as possible to prevent the transmission of this hazard group 3 organism. Of course, this pathologist needs to go home to their family after performing these autopsies. Therefore, consideration has to be made for utmost safety of the pathologist and whomever is around them. Therefore, I would recommend full PPE consistent with hazard group 3 organism. Dr. Dwar.
I will concur with Dr. Walong, and I'll just take you guys back to the day that HIV became a very new disease. We were in the same situation. I remember during that time, someone diagnosed with HIV, nobody wanted to be near that person. The body was being buried immediately, there's no autopsy. So my point here is, this we've just discovered this disease, I think 3-4 months ago, and the body of knowledge is still becoming enriched, and with time probably things will shift and we'll know that it's not as dangerous as you think, and we'll reduce some of these stringent requirements. Yeah.
Okay, thank you for that. Meru level 5 is back again with the last question, and they're asking, after the death of the patient infected, how long does the virus survive to be transmitted? I don't know.
Wow. So definitely, at the moment, we do not know. And what's known about other viruses, we know that this is a fairly hardy virus. Some people have been saying that it's possible, especially from a diagnostic perspective, if refrigeration has been done, it may not be viable in culture. But we know that from our practice, we treat each body as potentially infectious all through. So we may not have a concrete answer, but we think that definitely it remains infectious as long as the body is still in a fresh state. Therefore, of course, there's need for very good handling of these bodies. Dr. Odwor, any comment?
I think I concur with you, and I just go back to my analogy of HIV. People didn't know about it until it took so long, and we relaxed our view about it. So it's the same thing. Maybe with time we'll be able to know much about it, and we'll relax all of these requirements. Yeah.
So thank you very much for that presentation. I'll finish with Eric Otach's comment, and he's saying, thanks for the presentation. More research and development of guidelines needed and rolling them to the counties. So that's the last question. Dr. Walong, Dr. Odwor, is there any final thing that you'd like to say before we end this session?
Right. First, I would like to thank you all for joining this conference call. And I'm going through the chat box and I'm seeing lots of responses there and nice comments. And thank you, Anne. You're saying I'm looking funny, and I think we'll have to stay. It's good to look funny during this thing. The other comments I'm seeing is that people are describing what they think is happening in the picture I've shown concerning the handling of the body, where there's all this crowding, and I can see most of you have identified that there's a lot of problem with that, and it definitely needs to be managed. So again, I would like to thank you all, and I hope we'll reconnect again at a different opportunity. Dr. Odwor.
Okay, thank you very much also for giving me the opportunity of disseminating what I know about this disease and the preparedness. And what I like to urge everyone just to be careful, whatever you do. We've seen how infectious this disease is. We've seen what is done to great people. And we are trying our best to ensure that it's contained. And mortuary, we are not leaving mortuary behind, containment, because we don't want a situation whereby a mortuary become a focus of new infection. But we are trying our best also to ensure that everyone is safe. Thank you very much.
All right. Thank you so much, Dr. Walong and Dr. Odwor, for creating time and for coming to give us this presentation. We really appreciate it. There's been quite a lot of fear when it comes to handling of the bodies of people who are diseased, and we thank you for the clarity. For those who are interested in CPD points, kindly send your email to knhresearch@gmail.com. Give us your name, the institution, and the county, and you'll get your CPD points in your email address. Thank you all for listening and for logging in today. Tomorrow we have a session with the ophthalmology team. They'll be telling us more about COVID and ophthalmology. And we look forward to seeing you logged in again. So thank you all for attendance. For those who had challenges logging in with audio, we apologize for that. Please log in with your audio next time, and we'll be able to hear your comments, or you'll be able to hear the presentation. So thank you all for the good comments. I'm sure Dr. Walong has received them. Have a wonderful evening. Thank you.